Thank you everyone for being here today. I apologize for not being able to speak German, so if I start to get too fast, just wave your hands around and I'll slow myself down. I am a neonatal clinical pharmacy specialist, and our pharmacy model in the United States is a bit different than I believe it is in Germany. So we do our undergraduate university studies. We then go on to do a 4-year Doctor of Pharmacy program. And then after that, I completed 1 year of general hospital residency, so all patient populations, and I followed that up with a 2-year neonatal pharmacotherapy clinical research fellowship. So I spent a lot of time in the NICU as well as doing different research projects. I've published on using Precedex for sedation and preterm neonates, so if anybody likes to talk sedation, I also have done quite a bit of that. So we'll get into, I feel like I'm kind of making a vibration now. We'll get into the talk, and again, if you have any questions, save them for the end, and we can discuss at the very end. Okay, perfect, thanks. So for starters, we'll just characterize some of the risks very briefly with the ENFit syringes and tubing system. We will review the risk of contamination of enteral tubes in neonates. We'll discuss some of the cleaning procedures for enteral tubes, specifically the ENFit tube. We'll summarize some of the enteral medication safety principles in neonates, and then describe some of the literature related to enteral device dosing accuracy. So just as a quick background, I'm sure most of you know this, but ENFit is the female syringe system. In the United States, we actually use a male slip tip design, and so it's a male syringe that goes into a female tube. So for us, this was a big change. I think a lot of you have had a female lure lock before, right? So maybe not as much of a drastic feeling of change when people went to this. When it was originally designed, it was intended for enteral feeding primarily, and really the concept of medication administration wasn't at the forefront when the syringe was being thought about. But then, as we give a lot of medications enterally in the neonatal population, this is a really big deal for those of us who work in the neonatal population. And then additionally, the syringes have gone on to have both enteral and oral applications. Originally, they did not, at least in the United States, have the oral approval for use, and so systems were worried about having to have an oral syringe and an enteral syringe, and weren't sure that those two systems would be compatible. That's no longer the case. There are some design concerns with the standard ENFit syringe. So at the tip, there's a dosing risk that takes up 0.2 mLs, and that's potentially an area where we can over or underdose by 0.2 mLs, which again, in the NICU, we know this can be an appreciable volume as part of a dose. And then we have the tubing tip that it connects to. And so this has potential for both dosing and contamination risk. And we'll get a little bit more into the tubing portion before we move into the medication administration and accuracy piece. So we know that in neonates, we often have to use the enteral route for feedings early in their course because they do not have the suck-swallow mechanism developed yet. This leads to a reliance on the enteral route for administration of both the nutrition as well as medications. And when we're talking about enteral administration, we're talking about, again, both the tube as well as the syringes. And so we have to consider both of these pieces when we're looking at safety and efficacy. It is important to note that given the nature of how premature infants feed, anywhere from continuous feeds to every 3 hours, that the feeding tube is in near constant contact with the feeding material, whether it's human milk or formula. And there are some studies that suggest just the presence of having an enteral tube in neonates is associated with an increased risk of late onset sepsis. It is not benign to insert enteral feeding tubes, and so this is something to consider when we're thinking about how often we should be changing them. So we know that they carry risk of things like aspiration, as well as tracheal or pulmonary perforation. We can get pneumonitis or pneumonia, as well as a pneumothorax. There are studies that suggest that enteral tubes can be colonized in as little as 48 hours and sometimes as little as 24 hours. And I know that it's a little different here. I've heard that in Europe or Germany that you guys can only leave your feeding tubes in for about 28 days at most. In the US, we can use them up to 30 days dependent on the type of tube and patient factors. We know how they like to get those little fingers in and pull them out. So it's not uncommon that it's much shorter than that, given that we have to replace them quite frequently. So when we're looking at the colonization of the enteral tubes, there are many sources for these bacteria, and this is important to note as we look a little bit more at some of the clinical outcomes that have been studied so far. So we know that it can come from the oral, nasopharyngeal, and skin microbiota of the infant itself, as well as getting some of those flora that the maternal flora, as well as family and care providers, and so this is why some of our hand hygiene practices are so important. It also can come from the feeding source, and we know that there are various types of organisms that may be present in fresh maternal milk. Donor milk is potentially a source, and then infant formula as well. Many of these tubes can go on to develop biofilms, and this is very important because it enhances the bacterial resistance to antimicrobials as well as any sort of hygiene cleaning agents. And so once that biofilm forms, it becomes very difficult to penetrate that if you were to try to do something to target it. There are many factors that influence why neonates specifically may be susceptible or at risk with enteral feeding contamination. And I want to point out, we know that enteral feeds can be a source on their own, contaminated enteral feeds. So, there's published case reports and series of formula that has been contaminated with bacteria that makes infants sick, as well as some other sources. We know that on its own can cause infection, serious infection, meningitis, death, et cetera. And so it is biologically plausible that having this source in the tubes can also lead to potential for infection. We know that neonates have immature immunologic and gastrointestinal function. They have increased intestinal permeability, and then they have often dysbiotic intestinal flora. And we know that this develops very quickly, and it has many associated factors: prematurity versus term delivery, vaginal versus C-section, and then types of feeds and antibiotic exposure. So I just want to briefly run through some of the published outcomes associated with enteral tubing contamination. So as far as some of the microbiology, at least one study found nearly 20% of the enteral tubes were contaminated with Staph aureus, so again, going back to some of that skin flora, and half of those were actually methicillin resistant, or MRSA. And we have another study where they inoculated Enterobacter into the tubes and found that they quickly formed biofilms, and that as time went on, the biofilms started to break down and the bacteria were released into the tube and then out as they flushed them. And then another study looked at Enterobacter inoculated tubes, and they found biofilm development within 24 hours, and that when they flushed the tubes with sterile formula, the formula that came out on the other end of the biofilm tube contained the same bacteria as what was in the biofilm. So we know that there is potential for these microboluses of bacteria whenever we're going to be flushing or putting feeds into these tubes. I also wanted to briefly touch on some of the medication outcomes. One of the more fascinating things that I found is that 2 of the studies specifically commented that the baby's antibiotic exposure did not influence the type of organisms that grew into the biofilms in the tubing. And I think that's important because, at least as a pharmacist, I always think, try to minimize antibiotics. There's a lot of bad things that we can do with unnecessary antibiotic use. And these 2 studies both demonstrated that that did not appear to influence what was happening with those tubes in the biofilm. Another interesting note, I don't know if probiotic use is common in Europe, but they actually found that probiotic use wasn't negatively associated with the biofilm, but didn't comment on whether or not it did anything to help. Also interesting, I don't know how much people use acid suppression agents here, but we're trying to get away from that in the US. We know they're not nearly as benign as originally thought. But this study actually showed about double the rate of tubing contamination when babies were on histamine 2 receptor antagonist. And so I think that's really important too, is that not everything we do and not everything we put into these babies has no impact, and we have to always kind of be thinking in the back of our minds some of the less obvious downstream effects. And then looking at the type of feeds that these infants have received. So they actually found in one study that with mom's own milk, the gram negatives were lower as compared to a combination of mom's milk plus formula or formula alone. But interestingly enough, in another study, 93% of mom's own milk had Staph aureus in it, as compared to 37% of donor milk and only 11% of the formula babies. So it does seem, and that may make sense if you have mom's milk and skin flora, that's getting potentially into the milk. So then here are some of the safety outcomes I briefly wanted to touch on as well from one specific study. So interestingly enough, in babies who were formula fed in this study, if they had contamination, 75% of those demonstrated feeding intolerance, whereas if the tube was not contaminated with bacteria, 0% had feeding intolerance. So I think that's really important too to note, if we're having a baby who's having feeding intolerance, is this something to do with potentially the tube having bacteria growing on it, and we're kind of bolusing it again every time we feed. Another really important and interesting outcome is that weight gain was about half of what it was for the non-contaminated baby. So if your tube was contaminated, you only grew about 95 grams per week, as opposed to nearly 180 grams per week in the babies who did not have contaminated tubes. And then finally, I think the most concerning outcome from this, so about 20% of these infants went on to develop necrotizing enterocolitis. So 10 patients, not a huge study, but of those, 20% had greater than 100,000 colonies of gram-negatives, either Klebsiella or Enterobacter. 7 of those went on to develop necrotizing enterocolitis, 4 of which required surgical intervention. And then they cultured the peritoneal fluid on those babies at the time of surgery, and the peritoneal fluid cultures grew the same thing as what the tubes grew. So again, this is an important potential source of something like necrotizing enterocolitis. And then finally, I wanted to touch on the one study that's really been published so far on the impact of the tubing design on bacterial growth. And so you can see that the two types of caps that were studied in this particular study were a plunger cap versus a recessed cap, and they found that the recessed cap had significantly more growth than the other type of cap. And so they found that the overall tubing material didn't matter. The most important thing was the design and how it grew. And so I think it's just important to note that we can't assume all tubes are created equal, we can't assume all designs are created equal, and that there may be differences that we don't particularly understand yet that impact what we're seeing in our babies. So to briefly recap, neonatal enteral tubes may become quickly contaminated, and this is pretty close after time of insertion. Presence of pathogenic bacteria and biofilm are fairly common, at least in the studies that we have available. Potential negative outcomes include necrotizing enterocolitis, feeding intolerance, and poor weight gain. And then we also have to consider medication impact, not just that potentially the antibiotics are not harming this. We don't know really the outcome of probiotics, but again, pharmacy brain. We also put medications in these tubes, not just milk. And a lot of our oral medications are things that we're using from older children and adults, and they have sugars and sweeteners and different sticky things that like to stick on tubes. And this is potentially another source of nutrition for these bacteria. And so I think it's also important to note we don't really have anything currently in the literature that describes the impact of medications on top of these enteral feeds. And again, the tube design does make a difference, and so always thinking of this as we're making choices. So there are some things to consider with the ENFit tubing system and a cleaning process. We have the picture up here on the right. So it is noted that milk and medication can easily spill over into the wells of the moat. The moat, again, kind of being that recessed circle piece. It also has a locking mechanism, so it's threaded, and those threaded interiors can be difficult to clear of debris and residue. GEDSA, which is the global organization that helped develop ENFit, does have slightly specific cleaning recommendations. So you can see up here, they recommend at least daily, and then additionally, anytime that you see any debris or residue within the moat. And this is the GEDSA recommended cleaning protocol, which is about 7 steps, but they do recommend repeating the process, steps 3 through 6, until the hub and the cap are completely clean. So there is one study published on different cleaning protocols for the ENFit system. They actually looked at a 17-step process, which they considered more diligent, and then a 9-step process, which they considered less diligent. And they also looked at using the single-use ENFit cleaning brushes versus using a hard bristle toothbrush. And I know there are several hospitals in the US that use the toothbrush, and then they keep it separate from patients who have actual teeth. So they have their tube brush and their toothbrush, and they use that for up to 28 days. So just to think about our nursing colleagues, if you were to be cleaning this every time you access the tube, so say the baby's getting fed every 3 hours, and you were following a 9 to 17-step process, in your day, that would be an additional really 70 to kind of 140 extra steps that nurses should be completing to make this as clean as possible. And so that becomes a big burden. I don't know how the nursing assignments work here, but oftentimes our nurses may have anywhere from 3 to 4 babies, and so having to do 140 steps 8 times a day would be quite burdensome. So for this particular study, they looked at 2 formulations. So they had a chocolate enteral formula so that it was easily visible with the eye, and then they looked at something called Dazo, which is a gel that's invisible to the eye but visible with UV light to see, how well are we actually cleaning when we don't see something in the hub of the tube. So they did it on a 3-point scale, 0 being no residue, 1 having some residue, and 2 having significant residue. And then nurses evaluated their own cleaning process. So they looked at, I clean the tube, and this is how I view how much residue is left. And then they had blinded investigators who had the tubes and had pictures of the UV light and said, how do you rate these tubes? So can anyone guess if there was a discrepancy there? So looking across all of the tests, so both the chocolate milk and the Dazo, and combining the nursing evaluation of their own cleaning process as well as the blinded investigators, for our diligent cleaning process, nearly 70% still had residue. So it only worked about 30% of the time to clean with 17 steps. In our less diligent cleaning arm, nearly 90% still had residue. So that only worked about 10% of the time. And then when we looked at nurse self-evaluation of their cleaning protocols versus the blinded investigator, the nurses rated themselves as having done a great job, so they only saw 16% of their diligent tubes still had residue, and about a quarter of their less diligent arm had residue. So what this kind of tells us is that the caregiver perception of how well they're cleaning is a little bit more biased compared to people who are just looking at the tubes. The overall effectiveness of this cleaning process is poor. And again, we don't know yet the clinical implication of this, but extrapolating from what we have with other published enteral tube contamination studies, it certainly gives us pause for concern. And I think we need further evaluations, including microbiologic studies, to really determine if there is a clinical impact that might be making something worse for our patients. So we actually recreated this study to an extent. We didn't look at cleaning protocols, we just wanted to see baseline level of contamination. So we compared, which I didn't have for you here because you guys don't use the male slip tip system, but we used the female tubes most common in the United States and compared it to the Nutrisafe 2. So we looked at 40 Nutrisafe 2 tubes. We used chocolate milk and Dazo, and we actually ranked them 0, 1, 2, and 3. And so for 0 was no residue, 1 was residue that was just on this kind of outer portion that sticks out a little bit, that male lumen. A 2 was if you had some residue on that kind of male lumen and then going into less than 50% of the inside of the tube. And then a 3 was total contamination. There was residue everywhere. And so we do have some important design differences that may make the Nutrisafe 2 tube a little less prone to needing a cleaning process, and it's not recommended for the Nutrisafe 2 to have a cleaning process. But you can see that we have some, it's overall smaller. That portion of the male lumen sticks out a little more than it does on the ENFit low-dose tip. And there's kind of larger threading pieces inside of the ENFit low-dose tip that stuff gets stuck around, whereas it's a little bit more streamlined with the Nutrisafe 2. And I will say they have large models that are magnet pieces you can pull apart and play with and see what the inside of those tips look like that I thought was really interesting yesterday. So we had 4 independent evaluators look at the cleaning of these tubes after, or looking at the contamination or residue of these tubes after testing the chocolate milk and the Dazo. And so when we looked at just what they look like after fake administering a medication, the mean score was about a 1.1, so the majority of patients had at least a little bit of residue around that external male lumen. But then when the tubes were flushed with water afterwards, which could honestly be formula water or whatever, we looked again, and no tube demonstrated residue inside of that cap after it was flushed behind with volume. We did, again, not utilize a cleaning process. But again, we still need more evaluations of this as well, and potentially microbiologic studies, because I think that would help kind of answer some of our remaining questions we have. So to kind of summarize what about the tube cleaning, we do know that ENFit tubes, it's necessary to clean them, and that includes both the feeding port and the cap. And again, that is a recommendation from the global manufacturers that it should be cleaned, and their recommendation again is at least once a day and then anytime there's visible residue. I would argue based off of the ENFit study that even if you can't see residue, it's there, so it probably lends itself towards more cleaning versus less cleaning. The currently published ENFit cleaning protocols don't really do a great job, but we can't rule out that there is no risk. And so again, I think to err on the side of safety, we should be instituting cleaning protocols if we're not already. Alternate enteral tube designs may have some advantages over ENFit with less threading, and then the external male lumen is more prominent, and that's the piece that's really connecting in with the syringe. And then kind of the usual further studies are needed to clearly define any sort of microbiologic or clinical outcomes in this patient population. So now I'm going to move on to the medication safety portion and dosing accuracy. From a pharmacy perspective, that's the part I find most interesting, although I do also like the microorganism piece. So as we all know, neonates are particularly sensitive to medication safety errors. In the literature, there's up to about 80 medication errors per 100 errors for neonatal patients. The most common types are prescribing, administration, and dosing. Device-related errors are not as commonly published on, but it does appear that the liquid or oral formulations are more prone to error than other types of medications. And it has been implicated, the devices have been implicated as a source of error, particularly in low health literacy caregivers or parents. So when they've brought parents in and said, can you show us how you're measuring these doses, they found a markedly high number are not measuring the doses correctly at home. So we do know there's at least some potential for risk there. So again, the ENFit low-dose tip and ENFit was designed per the ISO standards. And again, it was intended for enteral administration of feeds. So if I give a little bit extra milk to a baby, it may not matter that much, but if I give a little bit extra medication, that potentially can have a clinically significant outcome for that baby. There's not a universal dosing accuracy standard for oral or enteral syringes, and that's, I think, one of the more interesting parts. A lot of times we think we're extrapolating from IV accuracy, but there is not actually a standard for oral. One of the most challenging parts of this is capturing dosing inaccuracy in neonates, because we know that they don't talk. They can't tell us if they feel different or bad from a medication administration error. One of the things that we do in the United States that I think is different from Europe is that every dose for every medication for oral and IV gets drawn up into a patient-specific syringe by a pharmacy technician. It is checked off and signed off and scanned by a pharmacist. There's many hospitals that actually use a camera system that takes pictures of every step so that if there's a question of an error, they can pull up the picture and say, no, this was 0.5 mLs, the correct dose was dispensed. And then it goes to the nurse who checks it off, scans it before giving it. And then for higher risk medications, a second nurse will actually sign off as well. So every dose has at least 3 sets of eyes looking at it before it gets to the baby. But again, oftentimes we don't have drug levels associated that we can check if we assume that there's maybe a potential issue with the dosing. And I think the education piece of people knowing if you're using the ENFit system, there is risk of dosing inaccuracy. That's, I think, one of the most important parts that we can kind of focus on is if you see a baby acting abnormally, and before we start chasing sepsis workup and all the things, or we do chase that and it's all normal, we consider maybe there was something not quite right about the dose that was given. So again, we don't have an oral standard. There are IV standards for accuracy, which is plus or minus 5%. In all of the ENFit industry-sponsored studies, they use plus or minus 10%. And there are some published, there's at least one published paper that did a survey asking people what they would assume was the correct amount of rounding or accuracy based off the type of medication. And so if you're talking about medications with high risk of toxicity, it's really down to more like a 0 to 1%, which I'm not sure is actually feasible. And then for our less toxic, less risky drugs, it can go up to 10 to 15%. So somewhere between 5 to 10% is probably falling in the middle. And again, most of the studies that have been done, including some of the ones that I did to emulate what was looked at previously, we used 10%. So we have a lot of challenges with medication administration for neonates with the enteral route. I don't know how it is in Europe, but commercial preparations in the United States are often limited. So there are things that we're needing to compound from either tablets or make different dilutions and such. There's a lack of standardization in the United States about what people use if you do have to compound, which can make it challenging when transferring between systems. And then oftentimes, again, our concentrations were intended for larger patients. So to get the neonatal doses, we may be measuring something that is almost too small to measure. And so the frequent thing I hear back is, well, just make it less strong then. So make it a bigger volume. And I have up here an example of our actual feeding protocol in my NICU back in the US with a 0.5 kilo baby. And we start the enteral feeds very small. And so you can see, we do trophic, or we do oral care at first, the first day, which is about 0.1 to 0.3 mLs, and then you kind of start to work your way up. But on day 2, they may be getting 0.6 mLs Q3. So if we just made our drugs a bigger volume and I gave something that was 2 mLs, that's going to greatly exceed how much food they're getting, and that has risks in and of itself. I also often hear, well, do babies even get things that need accuracy? And that's kind of always funny to me because I feel like that's usually from people who don't actually take care of sick babies. So I have some examples here of some different medications. This list is by no means exhaustive, but when we're looking at things like some of our seizure medications, particularly phenytoin, which has unreliable pharmacokinetics, even seemingly small fluctuations in dose can be problematic. And then kind of moving through the system, or moving through the chart, we also have things like our opioids. So the opioid epidemic in pregnant women in the United States is pretty terrible, and so we see a lot of babies that are born with neonatal withdrawal. And then things like our cardiovascular meds like digoxin, enalapril, as well as some of our HIV medications are also ones that have fairly low volumes that if you were treating a baby or prophylaxing a baby with a mom that has high viral loads, there's potential for, if you overdose, severe toxicity, and if you underdose, your baby could end up with HIV. So kind of popping back over to the standard ENFit syringe, back in about 2015 in the United States, they brought it to the clinical community at CHOP, and there were a bunch of different people that were there, and they all saw this syringe, and they saw the way there was a potential for 0.2 ml over or under dosage, and they said, nope, this is not okay. We cannot do this. This is, we were working with tiny sick patients, and 0.2 is clinically significant. So at the time, there wasn't a solution. There were just several workarounds to the problem, and so this really caused a lot of backlash from the clinical community in the US at this time. And so when you look at the graph that, again, this was done by the GEDSA folks, and they looked at the dosing accuracy of 1 ml ENFit standard syringe, and you can see the spread on this is significant. And so you have anywhere potentially underdosing of minus 30% to overdosing as much as about 50%. And this really was not acceptable. So we know that piece. And we know that, really any medication that's up to 2 mLs has potential for clinically significant dosing inaccuracy. And so this is a known entity. So the low-dose tip was made as an answer to this. And so there were a couple of modifications, and you can see them up here. We have the internal male lumen that was added to the female tip, and this created an area called the moat, and that was between the male lumen and the outer ring of the tip. And then, go back. In the United States, we commonly have the oral adapters that screw onto this because there was concern with that ear flap that if you put it in a baby's mouth, it could cut it or cause damage. And so this opened up a whole new potential for error by adding an additional piece to the end of that cap. There was an early computational fluid dynamics study. So again, that standard tip is 0.2 mLs of potential displaced volume, and of the standard, and the low-dose tip is 0.12. So the only thing that it potentially did was decrease the amount that could be displaced by 0.08, but it by no means stopped the problem. So there are an overall lack of peer-reviewed literature that document the performance of the ENFit enteral syringes, and also the available oral administration syringes that we have in the US, like the male slip tips. And then there's a lack of published really performance data across the board, so including the Nutrisafe 2. So the FDA in the United States, which is our Food and Drug Administration, they sponsored a study, another computational fluid dynamics study, looking at this because, again, the pediatric clinical community keeps pushing back and saying, I'm just not sure, I don't know that this is a good thing, we're not sure it's safe, we're not sure it's accurate. The ISO 20695 standard kind of calls this out and says that the low-dose tip does not reliably improve dosing accuracy over the standard ENFit. So again, this is a global standard that says the low-dose tip did not reliably correct dosing accuracy over the standard. So if you look here, we have the dosing error on the left, and then across the bottom, the nominal capacity administered. And they looked at orientation, so ENFit positioned down versus ENFit low-dose tip positioned up. And you had potential for dosing inaccuracy up to about 250% if you were positioned with the syringe pointing you're administering from the up position, from the down position, upwards of 300% potential for overdosage. So this was again confirmed in a different type of computational fluid dynamics study. And then when they looked at some of their additional calculations, overdosages that they thought were kind of the averages based off the different conditions they tested. So for a 0.5 ml syringe, about 35%, and for the 1 ml syringe, about 20%. So one of the things that we did very early on when I worked previously at University of Florida is we wanted to look at the accuracy of these pieces because we were concerned and our system was pushing to do the conversion. So we used all the FDA-approved instructions for use, and we were looking at the number of tests that fell outside of the acceptable range of 10%. And we completed a total of 576 assessments. So what's interesting to note, so if you look at what's kind of published, they'll say, oh, well, the mean dosing variance was less than 10%. And that was for the ENFit low-dose tip as compared to our male legacy, which is around 3.9%. But look at the spread of how these kind of shake out. And I've got a picture on the next slide that kind of shows you what percentage of tests actually fell outside of that acceptable range. And so our overall dosing variance, again, looks like it falls within the plus or minus 10%. And if I were, you could use this data the other way and say, well, look, it does work. But when we look at breaking it down by the low-dose tip and the syringe sizes, so overall, with our low-dose tip, 21.2% of those tests that we completed had an unacceptably high dosing variance. And when we break it down by the 0.5 and the 1 ml syringes, so about 37% of our 0.5 ml syringes had unacceptable dosing variants for the low-dose tip, and about 26% of the 1 ml syringes had unacceptable dosing variants. So it looks a lot different when you realize that a quarter to 40% of every syringe you may be drawing up in a day has unacceptable variants. And that's something that really resonated with us as well as the health system that I was working in. So we did recreate this over the past year with the ENFit low-dose tip versus Nutrisafe 2 because I'm now at a different hospital and the conversations keep coming up of what do we do when the manufacturers stop providing the mail system that we have. So we looked at 150 low-dose tip versus 150 Nutrisafe 2 syringes, and we looked across a variety of conditions, so medication bottle versus medication cup, and then kind of broke it down by size. So here we can see the dosing variance. It actually fell about 11.9% in this evaluation with the low-dose tip versus about 3.3% for the Nutrisafe 2. This is actually pending publication. It was recently accepted, but I don't have the reference information for it yet, but this will be available to you hopefully soon. And again, looking at how many tests fell outside of the dosing variance window, we found 48% were outside of the window for the low-dose tip, as compared to about 5% with the Nutrisafe 2. And so we again found, which confirms our previous study as well as what we're seeing with the computational fluid dynamics modeling studies, the low-dose tip is likely to result in high dosing inaccuracy and potential for overdosage. We then broke it down by syringe size. So we have our 0.5, our 1, and then it's a 2.5 versus 3 ml for the ENFit low-dose tip versus Nutrisafe 2, and found kind of comparable to what they see in the FDA computational fluid dynamics as well. The smaller the syringe size, the less accurate, kind of across the board, but at least for the Nutrisafe 2, it was still all within a fairly reasonable range. So it's very interesting because at the end of the FDA-sponsored computational fluids dynamics study, they say, yes, it's inaccurate, but there are some fixes for this. You can use a filling adapter, but they didn't actually study this. So I don't think they can definitively say that using the bottle cap will fix the issue of inaccuracy. So I feel like a little bold to recommend a fix you didn't study and you cannot be certain is the case. And then they also said to use 2 syringes for every dose administered. So you give a dose, unscrew it, get a flush in a second syringe, and screw that in. So from just a workflow and an economic standpoint, if every single dose we administer requires 2 syringes, that's just it's simply not practical. So we did look at the bulk bottle with the adapter and the medication cup. And we actually didn't do the straws that are recommended, or you don't have to use the straws, but they say you can use them for medication cups. We did not use those because there isn't a comparable adapter for the Nutrisafe 2, so we just wanted to see how they performed against each other. And so for the low-dose tip, it was around 13.3 for the dosing variance versus about 4 for the Nutrisafe 2. And then the medication cup, actually with no adapter, was the most accurate for the low-dose tip. So again, kind of not going along with what the FDA recommendation was based off of the analysis they didn't actually test. So what we found is that the bottle cap adapter does not actually improve accuracy, and so this is not the fix for the accuracy problems with the low-dose tip. So just kind of wrapping it all up, ENFit low-dose tip syringes carry a high risk of dosing inaccuracy. Primarily, it appears to be overdosages, but I also want to remember, especially if you're using some of the oral adapters or other pieces, underdosage is also a risk. The recommended methods for overcoming the inaccuracy were not tested by the group that recommended it, and we did not find that made a difference in our clinical evaluation. And we really need some further regulations to establish standards for enteral device performance, because I think that people can stand on the fact that there isn't a standard. And I think that that's something that we as the clinical community can kind of push back and say, no, but there should be. And that's not on us to decide, that's on industry to decide kind of how to do that. And we know that this is probably particularly important for our high-risk populations like our micropreemies and such. So we do know that neonatal dosing accuracy matters and that enteral doses and their accuracy matter. We're working with low volume doses with almost every medication that we give. And again, those signs of toxicity or treatment failure will be very subtle and they can't tell us. And so it's important that we are aware, we are knowledgeable, and we can use this to help our patients. And then really what we need for an enteral system in this population is something that's accurate, that's simple to use, and that has good hygiene, because we don't want to introduce additional risks beyond just the risk of being born too early. So with that, I will conclude and take any questions.